Hello, everyone. Good morning, afternoon, or evening, depending on where you are in the world, and thank you very much for joining us. We are so excited today to have Dr. Mohammed Al-Sweden with us, and he will be exploring the links between mood disorders and profound creativity. Today, he will examine the junctions between art, medicine, neuroscience, and ethics and attempt to uncover the secrets of what moves us emotionally as humans. Dr. Al-Sweden is an assistant professor of psychiatry at both Kuwait University and the University of Toronto, where he is cross-appointed to the divisions of brain, therapeutics, and philosophy, humanities, and educational scholarship. He also serves as the interim chief of psychiatry, founding head of mood and anxiety disorders, and inaugural director of education at the Kuwait Center for Mental Health. We appreciate you being with us today, Dr. Al-Sweden. Welcome.
Well, thank you so much. Just to make sure I'm coming in loud and clear. And thank you to everyone who's logging in from around. Perfect. So thank you to everyone who's logging in from around the world. It's really a pleasure to participate in this activity with the International Bipolar Foundation. I wanted my first slide to actually mention the work of this wonderful organization. It's an organization that is global in its scope, but very focused on the suffering and the trials and tribulations of individual patients and families on a day-to-day basis. And the work they do across the globe is really amazing. Part of it is this that we're doing today, the regular webinars that they have. They attend conferences throughout the world. They fund anti-stigma campaigns. And they've written manuals about dealing with bipolar disorder in multiple languages. And I'm discussing with them having that manual in Arabic soon, which would cover 30+ countries in the Arab world. So it would be really appreciated if you help this wonderful organization, whether through volunteering or donating, and the information is here on that slide. And for countries where you can get tax-deductible donations right off your taxes, it is considered a charitable organization, so you can tax deduct the amount that you give. So please do give and give generously to this wonderful organization. So let me go ahead and start the presentation. Oops, sorry. I don't know what happened. One second. I apologize. Okay, so let me go ahead and start. So what you're seeing here is a painting, a very famous painting. I've been lucky enough to see it in person a couple of times when it was on tour throughout North America. And this painting has a story behind it. Before I tell you who the artist is, some of you may know. This painting was painted when the painter got news from his brother, who was an art dealer. His name was Theo, that he had the birth of his first son. And when this art dealer wrote to his brother, the artist, that his son had been born and that he had named him after this artist, the artist at that time had been in a deep depression. And upon hearing this news, he never expected to name his brother, for his brother to name his son after him, because he's someone who had suffered from mental illness throughout his life, and despite gaining some fame in art, though not much in his lifetime, had been ostracized and marginalized in every city that he had lived in. In one of the cities that he lived in the south of France, he was called the crazy redhead. And the townspeople would, point at him, and children would laugh at him. And suffering from deep depression at this time, when he got the letter that his first nephew had been named after him, he switched from being in a deep depression into a manic productivity. And he wrote back to his brother saying, "How glad I am when the news came. I should have greatly preferred that you named the boy after our father, of whom I have been thinking so much these days, instead of after me, but seeing that it has now been done, I started right away to make a picture for him, to hang in the bedroom, big branches of white almond blossom against a blue sky." And he noted that the almond blossoms in this painting signified the birth of new life, as he was being born from his depression into his mania, and as the child was being born. So the child was named Vincent van Gogh after his uncle, Vincent van Gogh. And Vincent van Gogh will feature heavily in our talk today. He's someone who suffered from manic depression, or what we now call bipolar disorder, throughout his life. And many other famous artists, composers, poets, and those with profound creativity have suffered this illness as well. And in this talk, we're going to explore the connections between profound creativity, mood disorders, specifically bipolar disorder. Another famous individual who described how he felt during these manic fits is Edgar Allan Poe. Edgar Allan Poe is one of the most famous poets in the world, definitely one of the more preeminent American poets. And he wrote about himself that how he suffered in his illness, that he felt excessively thoughtful and wonderfully industrious by fits. So at times, basically, very slow, unproductive, and at times incredibly productive. And he says, I have thus rambled and dreamed away whole months, and awake at last to a sort of mania for composition. He called it a mania. For a mania for composition, then I scribble all day and I read all night, so long as this disease endures. And he actually documented how he felt in some of his poems, because he felt like this from childhood. And if you talk to many individuals who have bipolar disorder, as I do in my clinic and advocacy programs we run here, they'll tell you that way before they were ever diagnosed, they felt that there was something off, there was something different about their moods and how their moods made them feel, but maybe actually how their moods made them appreciate profound creativity. So Poe says in a poem, from childhood's hour, I have not been as others were. I have not seen as others saw. I could not bring my passions from a common spring. From the same source I have not taken my sorrow. I could not awaken my heart to joy at the same tone, and all I loved alone. So despite appreciating art during these mood swings, there's a very, very isolating feeling that I think would resonate with a lot of people who suffer from these disorders. Another poet, probably considered the most preeminent American poet, Theodore Roethke, who actually was around at the start of the pharmacological revolution in treating bipolar disorder, and was one of the first people to have lithium therapy, which actually saved his life multiple times from suicide. Says that when he describes, he looks back at his illness, he tells a story of at a time when he became manic. And he says, for no reason I started to feel very good. Suddenly I knew how to enter into the life of everything around me. I knew how it felt to be a tree, a blade of grass, even a rabbit. I didn't sleep much, which is a typical symptom in mania. I just walked around with a wonderful feeling. One day I was passing a diner, and all of a sudden I knew what it felt like to be a lion. I went into the diner and said to the counterman, bring me a steak. Don't cook it, just bring it. So he brought me this raw steak, and I started eating it, and the other customers made like they were revolted watching me, and I just imagined him kind of with blood dripping down his chin as he's eating this raw steak, because he has no insight into what he's experiencing. In that moment, he is a lion. And he says, and I began to see that maybe it was a little strange. So the loss of insight, the industriousness, the mania for writing and composition, goal-directed behavior, the loss of inhibition are all prominent features of the manic phase of bipolar disorder. This is a picture of someone very famous, but you'll recognize him by one of the most famous pieces of music in the world, which he wrote. Now, of course, I don't like using the word crazy, being a mental health specialist, but you often hear this in the colloquial sense of using the word. To compose something like that, that's so profoundly beautiful that it touches mankind for generations after him, Beethoven must have been crazy when he wrote that, and crazy in a good way, a good kind of crazy. But at the same time, he suffered. He suffered when he wrote this piece of music, which many musical scholars call the greatest piece of music ever written.
Dr. Al-Sweden, we're not hearing the music.
Hello?
Hi, I'm sorry, we're not hearing the music.
Okay, so you're not hearing the music. I'm sorry. So that was I hope you're still hearing me.
Yes,
But
still
that
here.
was I was playing yes, yes. So I had played the Fifth Symphony and the Ninth Symphony of Beethoven, and that was the Ode to Joy movement. For those of you who recognize the Ode to Joy movement of the Ninth Symphony, one of the first times in classical music a choral group had entered into a symphony. And Beethoven had suffered profoundly despite being creative. And his biographical scholars write about him that he had sudden rages, uncontrolled emotional states, suicidal tendencies, a melancholic disposition, so a very sad disposition, and very frequent feelings of persecution. Now, let's go back to the artist we talked about in the beginning. Van Gogh himself says that there are moments when I am wrenched by enthusiasm or madness, like a prophecy, or or a prophecy like a Greek oracle. So he feels almost like a divine intervention bringing in his creativity. And these artists and poets and composers are not alone. Many throughout history have been thought to have bipolar disorder if we look at their psychobiographies, which is the psychological study of their life experiences. So people like Emily Dickinson, Victor Hugo, Sylvia Plath, Charles Dickens, uh, Scott Fitzgerald, artists like Jackson Pollock, Michelangelo, composers like Tchaikovsky, contemporaries like Sting, Catherine Zeta-Jones recently came out that she has bipolar 2. Francis Ford Coppola, the director of the Godfather movies, and very famously recently, a very sad loss to the world, Robin Williams was a sufferer of bipolar disorder. And this connection between bipolar disorder and profound creativity has been wondered about not just today, not just in the last 10 years or this last decade, uh, even since ancient times. So Aristotle once asked, why is it that all men who are outstanding in philosophy, poetry, or the arts are melancholic? So they go through depressions. And if we look at Benjamin Rush, who's considered the father of American psychiatry, his face is on the emblem of the American Psychiatric Association. He was one of the signers of the Declaration of Independence. Very famous physician, wrote that, and this is in one of his textbooks, talents for eloquence, poetry, music, and painting, and uncommon ingenuity in several of the mechanical arts are often involved in this state of madness. And he was speaking of what would later be called bipolar disorder. And then we move on to Emil Kraepelin, who is the psychiatrist that divided psychosis into two parts: schizophrenia, which he had called dementia praecox, and bipolar disorder. And Emil Kraepelin had noticed this as well when he was describing manic depression or bipolar disorder. He says, this disease may, under certain circumstances, set free powers which are otherwise constrained by all kinds of inhibition, artistic activity namely. So Emil Kraepelin believed that the bipolar disorder was disinhibiting the human constraints that lock away creativity. Now, if we examine this under more recent methods of scientific evidence, does this turn out to be a romantic notion, or does this thought actually of this link between bipolar and creativity actually hold up? And so there are a number of early research paradigms, and by early I mean just in the last several decades, by many researchers. Some of the most famous ones are Kay Jamison, Nancy Andreasen, and Haga Pakiskel in the United States and the UK. And I'm going to focus on the work of Kay Jamison. Kay Jamison is the co-director of the Mood Disorders Center at Johns Hopkins University, and she's someone who suffered from bipolar disorder herself. She wrote many books about this, the most famous of which is An Unquiet Mind, which she writes about her struggles with bipolar disorder. She wrote a book called Night Falls Fast, and that's about her struggles with thoughts of suicide. But one of her more famous books is called Touched with Fire, which a lot of this presentation emanates from. And in it, she had researched the links between bipolar and creativity. So I recommend these books very highly. And she had done a number of scientific studies looking at this. So the background of Kay Jamison is that she used to live in the UK. She was a professor of literature. And she looked at mood disorders in writers and artists in a catchment area in the UK. And she found, compared to the general population, almost 40%, compared to a very small amount, we're talking less than 5% of the general population are receiving treatment for a mood disorder, whereas almost 40% of writers and artists were receiving that in the same catchment area. She looked at patterns of creativity in British writers and artists and compared that to, do they have mood swings? And she found that up to 45% of them have severe mood swings, and up to 90% of them have hypomania, which is a mini sort of mania, which is still considered part of bipolar disorder, and it can lead to behavior that's odd, that's noticeable by others, but can unlock creativity. Those are very high numbers compared to what would be expected in the normal population. Akiskel, who I mentioned in an earlier slide, looked at 23 award-winning European poets, painters, and sculptors, and these are people who had won awards at a national and international level, and he found that 69% of them had some form of mood swings, either in the form of what we call cyclothymia, so miniature mood swings, or to hypomania, which is a mini mania. Again, much higher. You would expect rates of less than 3% or around 3% in the average population. We're talking almost 70% in these writers, poets, and painters and sculptors. Now, are these links just because of the environment? I mean, one may say that artists are brought up in an artistic environment, and therefore some of that art rubs off. There's something called an eccentricity bias, which means that we accept eccentricity from our artists and poets and painters and so on. Or is it actually there? So one of the best ways to look at that, is it nature or nurture? Is it genetics? Is adoption studies. And this was a well-done study done in Scandinavia, where they actually looked at adoptees and the rates of high creativity in their adoptive parents versus their biological parents. So again, these are children who were separated from the biological parents at a very young age and raised by adoptive parents. And so if we see the rates of creativity in the adoptive parents matching that of the adoptee and the biological parents being lower, it means that it's the environment that's affecting it. It's not something that's genetic, just like bipolar disorder is primarily genetic. But what this study showed, if you look at the numbers here, is that those are who were highly creative, even though they were separated from the biological parents, their rates of creativity are very similar, 30% in the adoptees and 27% in the biological parents who they weren't raised with, and only 5.3% in the adoptive parents. So the social environment didn't affect things very much. Same thing in above average creativity, 10 in the adoptee, 8.3 in the biological parents, and much lower, 5 in the adoptive parents. And then when you get into low creative, then the differences kind of are kind of meaningless. So it seems that this genetic transmission of bipolar disorder also transmits profound creativity. So we have historical evidence, we have ancient philosophers pointing to this, we have psychobiographies pointing to this, we have epidemiological population level studies pointing to this link, and we have genetic evidence now pointing to this link. So it's quite a compelling story. Now, we've been talking about creativity all this time, but we really haven't defined what it is. A lot of things in life we take for granted. So let's define, what is creativity? Well, there's a lot of different definitions, and I've looked through almost all of them, and this is the one that makes the most sense to me. That creativity is bringing something into being that is both novel and useful. And this definition captures the distinction between creativity and eccentricity, and also the cultural relativity. So I could scribble on a wall and say that's creative, but if society doesn't deem that useful or novel, then it's not creative. It's just nonsense, right? And so there is some degree of arbitrariness to what is considered creative or not, but there's also a societal or cultural definition, and so this definition captures both. Now, okay, so we've defined creativity. How do we measure it? How do we know in more robust clinical scientific methods today that someone who has bipolar disorder actually has higher creativity than normal? Then we have to have a way to actually measure creativity. And there's 3 main ways to measure creativity. The first one is a term coined by a psychoanalyst psychiatrist named Albert Rothenberg in New York. And it's called the Janusian process. And what the Janusian process is, it refers to conceiving 2 or more opposites simultaneously during the course of the creative process. And he did experiments which were qualitative in nature, where he would actually interview Nobel Prize winning individuals, not just in the arts, but also in the sciences, because you can be scientifically creative. And one of the people he interviewed was Einstein, after he had won his Nobel. And what he was doing in these interviews was trying to find the moment of the Janusian process occurring in these different Nobel laureates. And in his interview with Einstein, which is, you can read the whole transcription of it, Albert Einstein, at a certain point when he describes how he came up with the general theory of relativity, describes a moment where the Janusian process is very evident. He says he was sitting watching a roofer fixing the roof of the house. And so those of you who don't live in Europe or North America, roofs in North America and Europe often have to be changed because of snow and weather conditions, especially the sloping roofs with shingles. And a roofer was standing on the roof of a house. Albert Einstein was watching him, and he imagined him falling off the roof. And he says, at this point, there came to me the happiest thought of my life. This is quite profound. Einstein saying this is the happiest thought in his life. In the following form, for an observer in free fall from the roof of his house, there exists during his fall no gravitational field. He goes on to explain that at a single moment, the roofer is both falling and not falling at the same time. So that's an example of a Janusian process. Two antitheses, two opposites existing in mind at the same time. And he credits this moment with being the happiest thought in his life that directly led to the formulation of the theory of relativity. Now, the problem with measuring creativity in the Janusian process is very difficult. You have to do qualitative assessments, interviews, maybe focus groups, and there's a lot of introduction of bias in the scientific process. You can project your own bias onto what you think is leading to measuring creativity or not. Now, here's a second way to measure creativity, which is called the measurements of divergent thinking. Divergent thinking is using unfamiliar premises as a basis for inference, avoiding common limiting assumptions. So Steve Jobs actually describes divergent thinking quite well, and I'll read this for you. So in one of his interviews, he said, creativity is just connecting things. When you ask creative people how they did something, they feel a little guilty because they didn't really do it. They just saw something. It seemed obvious to them after a while. That's because they were able to connect experiences. They've had and synthesized new things. And the reason they were able to do this was that they've had more experiences, or they've had more to think about, they've thought more about their experiences than other people. Unfortunately, that's too rare a commodity. A lot of people in our industry, obviously referring to the tech industry, haven't had a very diverse experience. So they don't have enough dots to connect, and they end up with very linear solutions without a broad perspective on the problem. The broader one's understanding of the human experiences, the better design we'll have. And one of the examples Jobs uses for his own divergent thinking is dropping in on a class of calligraphy at Reed College when he was a student, after he had dropped out and he was just auditing different courses. And Reed College at that time had the best calligraphy course in the nation, in the United States. And Steve just dropped in on it. And he said, had I not dropped in on that one calligraphy class, probably computers today would never have different fonts that emphasize typography and spacing between letters and indentation and so on, because he introduced that in the first Mac. All computers before then had the same font. And it was because of these different experiences and the divergent thinking. You can actually ask a participant to incorporate elements of divergent thinking while you're scanning their brain in a functional MRI scan or a positron emission tomography, or what we call PET scans, and look at things like asking a person to have creative story generation or visual stimulus description. And you can measure creativity that way. But again, that's very difficult. Now, a very elegant scientific solution comes from one of my mentors at Stanford University, Professor Terry Ketter and his group. Very elegant scientific work, where in the early 2000s they did a series of studies using something called the Barron-Welsh Art Scale. And this I find a very practical way of measuring creativity. So in the Barron-Welsh Art Scale, what they do is they show people a group of images, and for each image, a person is asked to rate how much they like it and how much they dislike it. So if you look at this first image of what looks like a polygon in the top left corner of the table, you can see that it's quite a simple image. And what people have to rate that image is how much do you like it, and then how much do you dislike it, and so on. And what was found in this study, where they compared people who had bipolar disorder versus what they called creative controls. So these are people who are creative who don't have bipolar disorder, and the way they knew they were creative is that they were product design students at Stanford University. It's one of the most selective universities in the world, and obviously a field like product design, you're bound to have everyone be very creative. And what they found was that the rates of, surprisingly, not the liking of the abstract images, but the dislike, the hate for the simplistic, was what separated both bipolar disorder patients and creative controls from the normal population. People with bipolar disorder and creative controls had rates of dislike for the simplistic images 700% higher than the average individual. And so the conclusion, there was a lot of conclusions from that group of studies, a lot of different conclusions, but the most important takeaway message was that it seems to be the negative emotion towards the simple is what ignites the creative fire for creativity, both in those who have known creativity without a mood disorder and those who have a mood disorder without known creativity. And that seems to be one of the links. Now, this still doesn't answer where does creativity come from. So we've answered to some degree the link that is, that it's there. There is a link that it seems to be genetic, just like bipolar disorder is genetic. It seems to be associated with the mood disorder, and it seems to be driven by the negative emotion towards the simple. But where is it all coming from? Now, over the last many decades, this was the theory that dominated the thinking around creativity if you talk about neuroscience, the so-called left brain, right brain theory, or what neuroscientists call the hemispheric lateralization theory, that so-called right-brained individuals are highly creative and left-brained individuals are very logical and mathematical. And this has been described in very romantic terms. This is an ad from Mercedes-Benz where they talk about left-brained and right-brained individuals. And I'll just read a little bit of this for you because it's quite poetic and it captures the romanticism that society puts into this. So on the left side it says, I am the left brain, I am a scientist, a mathematician, I love the familiar, I categorize, I'm accurate, linear, analytical, strategic. I am practical, always in control, a master of words and language, realistic. I calculate equations and play with numbers. I am order. I am logic. I know exactly who I am. And on the right brain side it says, I am the right brain. I am creativity, a free spirit. I am passion, yearning, sensuality. I am the sound of roaring laughter. I am taste. I am the feeling of sand beneath bare feet. I am movement, vivid colors. I am the urge to paint on an empty canvas. I am boundless imagination, art, poetry. I sense, I feel. I am everything I wanted to be. And many of you have seen the capturing of this romantic notion of left brain, right brain that came from a very small group of scientific studies where individuals who had seizures had what is referred to as corpus callosotomies, where the connection, the fibers that connect the left side and the right side of the brain are surgically operated on and cut to stop people who have intractable epilepsy that's not responding to medications, seizures that are not responding to medications. And that actually works because it stops the electrical conduction of the seizure across the brain. But the studies actually don't make a lot of sense. One of the things that clarifies that it doesn't make a lot of sense is that networks in the brain, now we're discovering, are much more complex than that. This is a more recent imaging of the brain through a technique called DTI, or diffuser tensor imaging, which looks at actually the flow of water molecules across different fibers of the brain. And we can see that the brain is connected not just left and right, but much more complex than that. The other reason that this doesn't make a lot of sense is, as we showed with Einstein earlier, it's possible for someone to be a mathematician or a scientist and still be profoundly creative in that field. Now, if we look at the hemispheric lateralization theory, we would think, well, they're left-brained because they're scientists. But yet they made quantum leaps in creativity in their field. So we need a new neurological model of creativity. And there's not one that's complete, but one model comes to us from this very interesting individual, Professor Alice Flaherty at Harvard University at the Department of Neurology. And she has a very interesting life story. When she was pregnant with her first pregnancy, she was carrying twins and she actually miscarried. And she developed some very strange experiences after that, some mood swings, depression, and she was actually hospitalized and developed something called hypergraphia, which is a rare manifestation of mania sometimes and other forms of neurological illnesses like epilepsy. And what hypergraphia is that people just write everywhere. She was writing on her arms, on the hospital walls. A lot of it was mumbo jumbo, but some of it was actually quite useful that she used in later parts of her scientific work. And she wrote a book about this experience called The Midnight Disease. What happened that was very interesting is after this miscarriage, a few years later, she became pregnant again, carried twins again, and delivered normally this time. But after her delivery, she developed very deep depression with very severe symptoms, suicidality, psychosis, and she was diagnosed with bipolar disorder, if I'm not mistaken, after that, or some form of a mood disorder. But she came up with a theory that, this sparked her interest. She's doing quite well, very famous scientist, very productive, and she came up with a theory other than the hemispheric lateralization theory. And for those of you who are not scientists in the audience, this is probably the most complex slide I'll show today. Don't worry, I'll walk you through it. Basically, there's two parts to the first part of this three-factor model, is that there is negative connections, where you see the minus, between the frontal lobe and the temporal lobe. So the temporal lobe drives disinhibition, creativity, and the frontal lobe is more kind of the executive functioning of the brain that inhibits that. So they mutually inhibit each other, and they keep each other in balance. And then there is dopamine projections from the mesolimbic areas. This is the areas of the brain that project dopamine, which is the major neurotransmitter of pleasure, of creativity, we believe, and it drives into the temporal lobes and into the frontal lobes. And it affects something we call latent inhibition. So latent inhibition is this ability of a person to filter out everything, all the information coming in. Right now I'm sitting in a room and I'm hearing the sound of the air conditioner, and there's cracks of the building settling in the evening where I am, and there's a light flashing outside my window and all these distractions. But how am I able to focus, just like all of us do on a day-to-day way, is that we have latent inhibition. All of this stuff is inhibited and you focus on the task at hand. So if you decrease this latent inhibition, it can be quite dangerous because you can't focus, and it may lead to, in fact, psychosis. But it may help the creative process. And so she describes in this chart, which is theoretical, along the x-axis, you see abnormal frontal activity. If there's too much frontal activity and too little dopamine, you can go into a creative block and into depression. But if you have a lot of abnormal temporal activity of the brain and increased dopamine, you can start going into the creative drive areas, but if it goes too far, it goes into mania and psychosis, which is the phase we see in bipolar disorder. So let's put all this together. We've said a lot of information, but let's summarize it in one slide. Basically, it seems that creativity is driven by negative emotion towards the simplistic, plus creative drive caused by decreased action of the frontal lobe, more action of the temporal lobe, and increased dopamine, and that seems to be the trigger of creativity. And many of these same processes are the same processes involved in bipolar disorder. Negative emotion, increased temporal activity, increased dopamine during manic phases. Why is all of this important? Is this just intellectualization? Are we just, kind of finding romantic and positive notions around bipolar disorder? No, I don't think so. Because I work with people who suffer from bipolar disorder. I know them, I know their families, and even though I've never suffered bipolar disorder myself, I can empathize greatly because it's most of the work that I do. And I know for a fact that people who have enormous potentials for enriching our human experience, for making quantum leaps like Beethoven and Van Gogh did, and Edgar Allan Poe and others and contemporaries and ancients, in creativity, often don't reach their full potential because either the treatments that we give them kill their creativity, or because they don't take any treatments and therefore live a very marginalized, stigmatized, or short life because of their illness. And so the challenge is to lift this veil, to unlock both the potential of the human and the potential of the creativity. And doing that is quite challenging. How do you actually treat with medications and psychotherapy, as most people who have bipolar disorder should be treated with, because it is a biological disorder that does need medications, but needs psychotherapy as well, needs understanding, it needs family support and proper sleep and exercise and all this wonderful stuff that comes outside medication. But at the same time, you don't want to over-treat. You want people to have some access to their negative emotion, which drives their creativity, and help them deal with that through non-medicinal techniques. Poe described this very well in terms of how his suffering could actually potentiate his creative drive. Again, in one of his poems, he said, "And by a strange alchemy of brain, his pleasure always turned to pain, his naivety to wild desire, his wit to love, his wine to fire, and so being young and dipped in folly, I fell in love with melancholy. So he actually loved his depressions at a certain point. Yet it's believed that that's what killed Poe in the end. So he understood very well what drives the creative fire. Let's return to the person we started with, Van Gogh. This is one of the last paintings he ever painted, about 6 months after that original painting, when his nephew was born and he went into a manic state. In those 6 months of his manic state, he produced most of the most famous paintings that we now know Van Gogh for, and arguably some of the richest artistic history of humanity was created during those 6 months. He probably had what we call today a mixed episode, a mixed city between mania and depression. So he was extremely productive but was suffering internally at the same time. This was the view from his room in the psychiatric hospital in the south of France to the wheat fields, which he had painted many times, but this is the most kind of depressing version of his wheat fields, and it's called the wheat field with crows. And he painted this wheat field many times. A few days after painting this, he walked out into this field, stood there alone, and then decided. He pulled a loaded gun out of his right pocket, turned it around, pointed it into his chest, and pulled the trigger. And he lay for many hours dying in that wheat field before he was discovered. And his brother was rushed to his side, and he actually died in his brother's arms 6 months after his brother had had his nephew, which he named after him. And he said his famous last words that he said to his brother, "The sadness will last forever." The sadness will last forever. Can you imagine someone on their deathbed, bleeding through their chest, having taken their own life, and even though they know their life is fading, to say at that moment, when there's only a few more moments in their life, to say, "This sadness will last forever." It's very hard to fathom, but that's how profound people experience the sadness. And just like he was profoundly creative, the sadness hit him that hard. This is one of his last known paintings, which is a painting of his psychiatrist, Dr. Gachot. And what he had, this psychiatrist, he didn't have any medications that he could treat Van Gogh with. And perhaps had Van Gogh lived longer, we would have seen even more of his paintings. But what he did do was that he, unlike other doctors Van Gogh had worked with, was encouraged him to paint, encouraged him to express his emotions through art, encouraged him to take walks with him, and he would discuss art history and poetry and music with him. He would treat him very kindly and posed for his painting as he did in this painting. And I think that's the challenge to mental health practitioners in this day and age. Can we actually take the experience of our patients not just as guidelines and numbers and psychopharmacology, which I'm a strong supporter of because it does save lives, but can we go beyond that? Can we listen to our patients, and can we modulate the medication in a way that maybe it leaves someone with a little bit of negative emotion if they want it, and deal with the rest with psychotherapy and exercise? It's very ethically challenging, but I think we need to step up. We need to step up. This is not just a game of numbers. This is real lives. This is the cultural productivity of humanity, and I think organizations like the one I'm working with today, the International Bipolar Foundation, facilitate that, because doctors, patients, mental health practitioners, advocates all work together at one table and study these very complex topics and try to come to a truth. Thank you so much for listening. This is a link to the program I run in Kuwait, which is kuwaitmood.com, which is the first center of excellence in mood disorders, as far as I know, in the Arab world. And we strongly appreciate your support as well. So kuwaitmood.com. And lastly, I'm going to show the slide for the International Bipolar Foundation, and we'll open up the floor for questions. Thank you again.
Great. Thank you, Dr. Al-Suwaidi, for sharing that incredible information. We do have a few questions. Let's see. First question, is there a readily available test of creativity that lay people can use?
So the Baron-Welch art scale, which I mentioned, is readily available, but it does need to be administered by an experienced psychologist, psychometrician, because there are rules to it. I don't know of any test that, there's a number of these things on the internet that claim to test your creativity, but a lot of these things, their psychometric properties, their validity and reliability have not been tested. So the fastest and easiest one to apply, which is actually quite reliable and valid that I know of, is the Barron-Welsh Art Scale. But again, that should be administered by a psychologist.
Great, thank you. The next question, or maybe it's somewhat of a statement, but this person is wondering why we don't teach what you've just shared with us in schools so that children don't feel the stigma from the get-go.
Yes, that's a very important statement, and maybe I'll just reflect on that. I think it is very important when we know that somewhere between 10 to 16, 17% on the country, varying on the country, of people have depression, that anywhere from 3 to 6% of people have bipolar disorder. So we're talking 1 in every 33 people has bipolar disorder. I think it becomes very important to recognize this. I think the problem is that stigma, at multiple levels, at the societal level and the governmental levels, within the field of medicine and mental health itself, there's a lot of stigma. And when someone is sick with asthma and they have difficulty breathing, and that comes in episodes, and they need to take medication for it, that's seen as okay. That's seen as it's not your fault. But once it becomes behavior or thinking or moods, suddenly it's the person's fault. And taking medication that affects the brain is suddenly unacceptable, even though episodes of difficulty breathing, it's acceptable to take medication for. So it's a mindset that we need to change. And in Kuwait, we're working on this. I'm working with a wonderful group called Taqabbal, which means accept. And this is a national mental health awareness campaign. And actually, in the last several months, we've done lectures at every single high school in 4 out of 5 governance in Kuwait. There's one more that we're working on. And our goal is to cover every single high school in Kuwait to give talks about stigma. And I think organizations, throughout the world, if we think of the United States, like the National Alliance for the Mentally Ill, the International Bipolar Foundation, the American Psychiatric and Psychological Associations, do stigma work. I think we need more advocacy at the government level so that this can be taught in schools as part of a curriculum. And it can be something around health awareness, health literacy, and mental health education. But it is becoming more and more not only accepted, but applied in a number of countries throughout the world.
Great, thank you. Do you happen to have an available packet on a website or some sort of PowerPoint that you do use when you visit the schools?
We do. It's not on a website so far. It's just been because the one we use when we visit schools, we try to use a standardized one, and the people that deliver this are usually psychologists or social workers or psychiatrists. And we do have, if in Arabic, there is a documentary which we'll be posting on YouTube soon. If you want to get the news about when we post this, if you follow on Instagram, Taqabbal, which in Arabic means accept, so it's at TAQABAL. So news of that will be posted. Or if you follow Kuwait Mood's website or our Instagram account, which is at Kuwait_Mood, all one word, or my Instagram account, which is at MO Al-Sweden, which and my name is spelled on the title slide of this talk. So at any one of those, once we post that information, it'll be available in Arabic. The American Psychiatric Association, as well as the National Institute of Mental Health in the United States, on their website has some information that is posted in the form of both slides and brochures. So there is a website called Healthy Minds. If you just Google American Psychiatric Association Healthy Minds, there's a website that has that. And even though it's not in the form of slides, the International Bipolar Foundation has their manual, which I believe Debbie can mention, but it's on the website. It's available.
Yes, absolutely. IBPF.org, as you see on the screen, and we do have a free book in PDF form that we will happily email to you. So please send me a request if you would like to receive that book. The next question, thank you so much for that answer also. Could you please talk a little bit about bipolar disorder in the Arab world? How much research has been done about it in that region? And what about stigma, availability of medication, and treatment options?
Right. The tough part of that question is the Arab world often people take as a whole, and it's quite variable. Um, as many listeners, if they're from the Arab world, will know that there are very, strong healthcare systems in some countries that are very well financially funded, and other areas where there are a lot of refugee camps and a lot of war and trials and tribulations are occurring. So the Arab world is not one conglomerate. There's a lot of differences. Having said that, some of the best research that's been done in the region has been done in places like Egypt and Lebanon, who have a long history of strong academic institutions. So there is some research there. I'm working with a group now that is looking at doing 10,000 telephone interviews randomly in a number of different Arab countries, including Kuwait, to screen for the prevalence of bipolar disorder. So once we have that, it's going to be published. I assume that the rates are the same as they are worldwide, because most countries worldwide have found the same rates, around 3%. At the lowest estimates, around 1%. Highest estimates around 6%, and 3 seems to be the most accurate number. In terms of availability of medications, Kuwait, where I am, most medications are available. There's only 1 or 2 medications that are quite new, that are still only in the North American market, but they're coming to us soon. But there are other countries where I've had patients contact me from where there's only a few medications available. Having said that, the medications on the essential list of medications from the WHO include the standard medication treatments for bipolar disorder are available in most countries. That comes from the WHO essential list of medications. Lastly, in terms of what's missing the most in the Arab world is psychoeducation for families and for patients, as well as psychotherapy. So we have a big deficit of people who can provide psychotherapy. And there's a number of well-validated psychotherapies specifically for bipolar disorder, other than not just what we call psychoanalysis or psychodynamic therapy and cognitive behavioral therapy, which are famous. But there's a new form of psychotherapy developed by Ellen Frank in Pittsburgh and her colleagues, and it's called interpersonal social rhythm therapy, which is very specific for bipolar disorder. So that doesn't exist, as far as I know, any place in the Arab world. In at least, you might find 1 or 2 practitioners that do it, but not a very well-designed program that has it. And it's just a lack of human resources. And I think, as we have more and more young people interested in psychiatry, psychology, social work, and start to study these areas, then we're going to have more practitioners with time. But we're a bit late to the curve in the Arab world.
Okay, thank you for that answer. The next question, do you think that the heightened senses that are often associated with mania contribute to the idea of divergent thinking, and how so?
Absolutely. I think that is part of it. So what happens in mania, I mentioned this term called latent inhibition, which is driven by the balance between the frontal and temporal lobes and the levels of dopamine. And what happens during mania is there's less latent inhibition. So all these senses around you, they're coming in all at once, and a person is able to process them and think about them all at the same time. It seems that when a person is hypomanic, so just low levels of mania, these senses can still be utilized because the person has not become dysfunctional. And once they go into a level of mania, then really, too much input is happening, and you really can't produce anything useful. Now, I hope this doesn't sound like I'm advocating hypomania, because as one of my mentors used to tell me, there is something in bipolar disorder called the emotional law of gravity. What goes up must come down. And often we believe that, depressions are often a result from uncontrolled hypomania or uncontrolled mania. And we know that bipolar disorder is primarily a depressive disorder. People who have bipolar disorder spend the majority of their lives depressed, not manic. And people who have bipolar disorder spend more time depressed than those who have unipolar depression in their lives. And this has been shown worldwide. And so really what we need to do is allow people to access some of that drive, some of that negative emotion, without tipping too much into hypomania or too much into depression. Now, and then it depends on the person as well, because one person might tell you, you know what, I want you to help me control these mood swings, even if I lose some of my creativity. So you follow the patient's lead. And other patients may tell you, no, I'm not. I'm a poet. I'm a composer. I'm not willing to lose my creativity, but I want my mood swings to be controlled enough that I can live a relatively functional life. And I know this is controversial, but some doctors would support me, would say you might want to follow the lead of the patient, not lose them, build a trust and a rapport, and working with them, maybe underdose intentionally, and deal with whatever is left with psychotherapy, exercise, and so on. Now, if someone is going into dangerous manias or suicide, of course you have to get to the standard dosing and get them controlled because it's a life and death situation. But really, I think we have to be more humble and follow patients' leads and kind of listen to the direction they're pulling towards, but also, try to give them some objective advice that is very difficult to see subjectively, and try to come to a middle ground that everyone's happy with.
Great, thank you. The next question. Is Kuwait Mood a hospital with referrals and overnight stays, or is it a counseling center? If so, what ages are accepted, and where can we make an appointment if we do accept appointments for therapy, etc.?
Okay, so thank you for that question. So it's neither of those. So Kuwait Mood is a unit within the hospital. It's a unit of service within Kuwait's National Mental Health Hospital, which is called the Kuwait Center for Mental Health. And there's a number of different units. There's general psychiatry units, addiction units, child psychiatry units. So Kuwait Mood is a mood and anxiety unit. It is not an inpatient care unit. Inpatients, because we're at a hospital, are taken care of by our general psychiatrists. We're an outpatient group. We have all of these services are described on the website, but for people who are in Kuwait, they can be seen as an outpatient if they have a mood or anxiety condition, get an assessment, be followed up for medication consultation, be referred to a psychotherapist, and their families can be referred as well to psychoeducation around mood disorders. So their families can go through a workshop, which is 6 weeks in duration, that helps them have better understanding, better communication skills, better coping skills in dealing, with their loved one who is suffering either bipolar disorder or depression. So a number of different activities that need to change constantly. We have a number of advocacy projects like Mental Health Movie Night, which we do once a month. The next one is coming up in a few weeks. So all of that is available on our website or on our Twitter or Instagram. And I hope that answers the question. So we're not a separate hospital. We're not a counseling center. We're a unit within the nationally funded mental health hospital, which means our services are free if you're Kuwaiti. And if you're non-Kuwaiti and have the national insurance, then it's very cheap to register at the government hospital and then see us. The trade-off, of course, is there's a bit of a waiting list. Usually we try to keep it not too long. It's not usually longer than a few weeks to get in to be seen.
Excellent, thank you. The next question is, have you written a book, and if not, do you intend to do so?
There's many things I intend to do, and I always aim for more than 100%, and then I try to do my best. Definitely, at some point in my life, I want to write more than one book. I've been toying with writing a novel that incorporates a lot of the experiences I've had in dealing with mental health problems, with mood swings, issues with identity, and so on. But at this stage in my life, I'm doing a lot of research, teaching, administrative work, and it's just hard to do that. I think eventually, in the next few years, I might take some time off and work on a book finally. Having said that, one of the young psychologists that works in my unit, I worked with her to write a manual that we use for family psychoeducation, and this was supposed to be an internal manual. But it's well written enough and been quite effective that we've been thinking of turning it into a book pretty soon, and that's going to be in Arabic, and it's about family psychoeducation and mood disorders. So there may be a number of projects from that perspective where we use some of the day-to-day activities that we do and turn them into manuals and books. So I guess stay tuned for the near future. It's something that's on my bucket list, and I think I will do someday once I dedicate the time to it.
Great, we all definitely look forward to that. The next question, in my experience, the ruminations that come with depression are a crucial part of the creative experience as well. Can you please comment?
Uh, s- uh, okay, so I think I missed the last part of that question. So the ruminations that come with depressive
Yes,
experience,
in my
and then
experience, the
and then what?
ruminations that come with depression are a crucial part of the creative experience. Can you please comment on that thought?
Okay, the ruminations, yes. Yeah, so as I mentioned in the talk, that it seems to be a combination of not only drive, but access to negative emotion that seems to drive creativity. And my guess, I don't have a back and forth with this person who's asking the question, but my guess would be if you really think about some of the ruminations, they may be about some depressive themes, but they often will involve ruminations about how mundane and simple and annoying things are, and that might reflect a negative emotion towards the simplistic, which may be the drive of if this person that's asking a question sees it as a drive for their creativity. These ruminations may be about the simplistic, which then are igniting this fire of creativity. Um, so it's not only during the manic phases. There seems to be some important access during the negative phase. As Poe said, I fell in love with melancholy. He didn't say I fell in love with mania. Um, so it seems to be both phases are quite important. So it does make sense to me that one person would experience it more during hypomania, one person would experience it more during melancholy. And in fact, I believe that most people who have hypomania, there's some negative emotion there as well. I believe that most episodes have a mixed aspect to them when we're talking about bipolar disorder. So there's almost no pure mania or hypomania and no pure depression. There's always features of the other pole there. And that's why I don't favor the term bipolar disorder. I like the old term, manic depression, because I think it captures both aspects. It doesn't emphasize just a person being in one pole or the other. It emphasizes more the cycling between the poles and the mixity of symptoms at the same time. And most bipolar patients that I talk to, when I say things like this, it seems to resonate. And that speaks miles. That speaks more than textbooks. Patients' experiences speaks a lot. So just some reflections there. I hope that makes sense or answers the question.
Yes, wonderful. Thank you very much for that. The next question, you referred to treatment such as um, referred to treatment that medication alone is not the best. Apart from medication, talk therapy, what are some things to couple with this to make this illness um, and creativity something to live well with?
Okay.
So,
So I'll speak in general about treatment and balancing treatment. So I want my message to be very clear. I am a supporter of biological treatments for bipolar disorder. Every piece of evidence I've seen, whether it's in textbooks or data or my own clinical experiences or the report of patients, points to that bipolar disorder is a very biological disorder. It has strong genetic correlates, and just like treating asthma or hypertension, at least in this day and age, until we have better science, there are medications, biological treatments, pills that people take that can really help this disorder. And so if you have bipolar disorder, I strongly suggest you see a psychiatrist, and if they recommend medication, I strongly suggest you go on it. Now, you should work with your psychiatrist to make sure that you're on a medication that your body can tolerate, that's not causing you too many side effects, that the benefits outweigh the risks. We know that every single medication has benefits and risks, even Tylenol for a headache, right? And all medicine is balancing these benefits and risks for the benefit of the patient. So that's part one. Having said that, that's not the whole solution. We know that's not the whole solution. One of the reasons we know that's not the whole solution is biological, because there are many deficits biologically that happen in bipolar disorder, such as inflammation, oxidative stress, deficits in the endocannabinoid system. This is the brain's cannabis-like signaling system. Neuronal regeneration, so this is the rebirth of new neurons in the brain. Cellular resilience, so this is how hardy brain cells are to destruction from toxic elements and inflammation that happen during mania and depression. All of these areas aren't touched with our current medications. And so then how do you target them? Well, it's been shown that different kinds of psychotherapy can cause brain changes in the way the brain functions. If you look at brain scans pre and post psychotherapy, the brain actually changes. And so talk therapy can actually make a difference. But you have to find the right talk therapist that you connect with and the right kind of talk therapy. Other things other than medications, there's a number of studies on using powerful antioxidants. Now, I'm not going to say which antioxidants that are over the counter, because I think you should discuss them with a psychiatrist, but the mood disorders experts would know some of these powerful antioxidants that recent evidence has been shown that if you combine them with the standard medications, they can help. Omega-3 fatty acids, for example, are something that don't have very many side effects. And I'm not saying our treatment alone for bipolar disorder, and by no means proven to be effective yet, but there's a number of compelling studies that show that they can help in the treatment when you add them. And I think first and foremost is physical exercise, and it has to be done at the right dose. So physical exercise, short, intense physical exercise, as many days of the week as possible. So what I prescribe, and I actually write it on a prescription pad and hand it to patients, is that you do 20 to 30 minutes of exercise, only 20 to 30 minutes, not beyond that, at a very high intense level. So you're sweating most of those 20 to 30 minutes for 5 to 7 days in the week. And there's a number of research studies, Dr. Roger McIntyre in Toronto and I wrote one of them, that shows that doing this dose of exercise can target portions of the brain and foundations of bipolar disorder that we can't touch with our current treatments. So it really is a holistic approach. Beyond that, I really believe in mindfulness. So this is what's referred to as the fourth wave of psychotherapy, which is a type of treatment that focuses on being present and aware in the moment, focusing on the moment when you're walking, when you're eating, when you're breathing. And that's been shown to have a huge effect on reducing stress, decreasing the number of relapses into depression or into mania. And I think family education is a very big deal as well. And researchers like Edward Vieta and Francis Colum in Barcelona have done the most interesting work on this, and showing that improving family psychoeducation around illnesses actually decreases the number of relapse in their loved ones, accounting for all other factors. So really, you have to, as Hillary Clinton said, it takes a village. You know, you really have to create this village of treatments, of individuals that are supportive, of how the person feels about themselves, about, you know, with advocacy to reach 100% improvement. It's not just a matter of popping a pill.
Excellent. That was a wonderful answer to his question. Thank you. Next question. Are there any studies that measure the prevalence of creativity among bipolar patients?
Are there any studies that measure the prevalence of creativity in bipolar patients? Is that the question?
Mm-hmm.
Yeah. So yes, and I believe I mentioned some of those studies in the initial slides. I don't know if the slides are still on, but I can go back to one of the slides. So, so this is, let's see. So this is one of the most famous ones. No, sorry, that's not bipolar patients. That's in writers and artists. So this, right? So the Baron-Welsh Art Scale compares levels of creativity to creative controls as measured by the Baron-Welsh Art Dislike Scale, and it was found to be similar. Are there studies where you take population level, you know, bipolar patients and look at their levels of creativity? There are a few. I decided not to quote them because some of them are not well done. They're mentioned in Kay Jamison's book, Touched with Fire, so you can see some of them. But this is one of the best ones that I know of.
Great, thank you for going back. I appreciate that. How short can a hypomanic episode be?
So, by definition, in the DSM-4 and the DSM-5, the shortest time a hypomanic episode can be is 4 days. Now, that number is somewhat arbitrary. I believe it can be even somewhat shorter. I don't believe that it can be, you know, a matter of hours. I think if it's only hours, then that's probably something else, or that's a mixed episode. But I think it can be even as short as 2 or 3 days. Now, I am, you know, I'm speaking outside the standard norm. The standard norm is 4 days. What I found usually, though, is that most people experience it much longer. It's the minority of individuals with bipolar disorder that have something shorter than 4 days. The majority have something longer than 4 days. Now, a lot of people will tell me that, no, well, I experienced it for hours or a few minutes. And what I would respond to a person like that is then probably you're not having a hypomanic episode. Probably you're having what used to be referred to as a mixed episode, now we call a mixed specifier. And so you're probably having both portions of hypomania and depression. And I think that's actually a very common, if not the most common, bipolar episode, which is a mixity of features.
Great, thank you for that answer. We have certainly run out of time. We have run over a little bit, but I want to thank everyone so much for joining us, and know that this presentation has been recorded and will be uploaded to our website to share with others or to reference back. Also, if you have any additional questions, please email me at dbrown@ibpf.org, and I'd be happy to forward those on to Dr. Alsweden.
And I can mention my my email. It's on the website on kuwaitmood.com, but it's also it's a very easy email. It's head, HEAD, at kuwaitmood.com.
Excellent. Thank you so much, and we definitely appreciate your incredible insight today. And I hope everyone enjoys their morning, afternoon, or evening, and hope to see you again at the next webinar. Thank you.